A 2020 World Health Organization report indicated that 599 people died of leukemia in Uganda, and that is 0.29% of the patients at the time. A later study indicated that 16.5% of the adults suffering from acute leukemia always succumb to the disease. That does not spare the children, because that is where we are going to put our focus today, about childhood leukemia. What does it manifest as? What is the problem? Where does it come from? And is there any hope for anybody that is suffering from leukemia in Uganda? A very good morning to you, and you are welcome. I am Viola Kusasia. This is NTV Medical Matters. We are supported by Bill and Melinda Gates Foundation.
Amanya nze Namatof Bridget, mama wa Deus aliganyira. Amanya gange zaliganyira adieri azetato omwana aliganyira Deus abadde omulwadde wa kansa.
Tusooka nawe mama, ono omwana Deus wamanyira wa oba wamanya ddi nti waliwo ekimuluma, waliwo ekitali kituufu oba nti mulwadde?
Omwana nasooka okumulaba kale nga ali bulungi, ng'alya ng'anywa ng'azannya, naye ate ng'agwerera. Ng'olaba agwerera ate ng'ali bulungi. Kati netandika gamba omwana ono ng'agwerera, ate nga tatwagamba omwana ali mu kkula. Kati bwe kyava mu kugwera natandika okufuna ka temperature. Nafuna temperature ntonotono nga bwe muwayo ku panado. Kati bwe namala ne mutwalako mu ddwaliro mu kiriniki entonotono ezaffe. Ne bangamba ina omusujja, ne mwayoko ku mpeke ez'omusujja. Nenga nazimu omwana ate nga yeeyongera kubeera bubi. Kati waliwo yatuuka embeera n'etabukira ddala n'abeera bubi. Natuuka n'okukankana. Ne ndaba omwana nga akankana. Kati ne tufunawo eddwaliro eddala ne tumutwala ne tumuddusa. Kati bwe twamutwala mu ddwaliro, oyo omusawo n'alaba omwana. Yagenda okumukebera omwana n'agamba talina musaayi. Musaayi guli wansi nnyo. N'otuuka n'omwana ekyokunywa nga tasobola kisika kasiki. Kati n'agamba tumutwale awo waliwo eddwaliro eddala bamupima omusaayi, balabe obungi bw'omusaayi. Kati bagenda kumupima ne bakomyawo ebbaluwa gy'ali, n'agamba omusaayi guli wansi nnyo, tasaana kutuuka 6 gwa kiro. N'agamba tetulinnya mmotoka, tulinye booda okutaasa obulamu bw'omwana. Kati obudde obwo omusawo yatusindika nagulu gye baatwala omwana.
Byagenda biti eyo?
Twamanduuza mwezi mulamba tuli ku bujjanjabi. Kati mubiseera ebyo waliwo dokita gwe wayitanga Dr. Butira, yatuuka naye ng'alaba embeera emuyinze. Nagamanyi mbajjanja buli kimu kyonna kigaanyi kambasindike mulago. Era sigaza Katonda akole kyaffe. N'agamba naye obumu twaffe tebunakwatibwako. Mwana naye ogenda ku treatment. Obulwadde obumuluma leukemia. Namubuuza leukemia okimanyi? Nga musawo nze simanyi musawo wa kidokita. N'agamba blood cancer.
Kati ogere katono ku treatment. Treatment bamuwa ya ngeri ki, yenkana etya?
Treatment ezasooka zakosa nnyo mulwadde. Ate nga sinza kikiza nti no bwana atereera bataatereere. Atuuka omwana nze bayita kemo. Yatandika kemo, nagamba kemo nga muzibu. Yatuuka akaseera nafuuka bulaaka, mwigo na bulaaka, njala bulaaka buli kimu. Nayiwa n'amabwa. Tugamba nagamba mugume mujja kutya Katonda yawonya siffe nefu tulabirawo.
Katudde wa mama, kati mama ng'ono omwana taata amukomeza we waka. Wamulaba otya ate nga walabawo nkyuka etya, kati ogere ku mmere, mizannyo ne banne, kugenda ku ssomero, byali bikyasoboka oba byonna byakyuka?
Omwana bwe yakomawo ewaka, kale waliwo lwe yakomawo nga yenna ageze nga munene, ng'ebitamanga binene, ate nviiri tekuli, olubuto olunene, kyonna nga kitambula nga kiringa kibooso, olubuto oluli eri. Kati bambi kale ekyasinganga okunkwasa ennaku abaana banne nga bamusekerera nga bamulaba alina akawalata ka Museveni nga mugamba ebitama ate bambi nga kimunyiiza ate oluusi embeera nga etuuka nga yeesosola nnyo mu banne ng'ayinza okudda wali ebbali n'abeera yekka nayimirirawo n'asirika oluusi nga bumuleetera obukambwe ng'abeera mukambwe nnyo wadde ku baana wadde ku bazadde ng'abeera mukambwe tewali olwo yatuuka ng'alya ng'ayinza okulya essowaani y'emmere ennene ng'agikuba wali mu ddakiika ng'agimalawo wayitayo eddakiika ntono nnyo ng'agamba nfu enjala ng'oddamu oleeta endala oluusi obeerawo ng'olaba omusaayi guva mu nnyindo guva mu kamwa ng'oyinza okulowooza alinamu ebiwundu naye nga temuli n'afuna amabwa mu kamwa nabanga takyasobola kulya ku mumiro mu lubuto nga gamuluma ng'akaaba okufa obufi asula akaaba asiiba akaaba obulumi nga bungi n'atuuka nga takyasobola nakutambula nga musitule n'atuuka n'akoga n'abanga skeleton just ndooza nga asereza sikini yekka naye nga buli lwemutunulako nga nkaaba buli ekyajjanga kyajjiranga mu maanyi netuuka neŋŋamba oba eddagala alirekeeyi erimuyisa obubi nga limuyisa bubi nnyo omwana nga ndaba atandise okulya nga takyalumizibwa kintu kyonna ng'olaba ne bwamira eddagala asigala ali bulungi amabwa tegakyajja ng'atandise okuzannya kale ng'olaba n'okuzimba nga kutoolokosi ng'olaba atandise okutereera obulungi n'enviiri ne zikomawo awo nanga amaanyi ne ganziramu.
Message olina ki esembayo ku muzadde ali eyo alina omwana mulwadde naye nga amukwesa eyo munda tayagala abantu bamulabe alowooza oba witchcraft oba kiki?
Nze kyenkubiriza abazadde tubeere nnyo nga twetegereza nnyo abaana kubanga ti omuzadde kati ngaffe bamaama omwana abeera waka oba omumanyi n'omanya nti ono omwana ali bw'ati kati akyuseemu ali bw'ati kati bw'olaba omwana we oluusi akendeera wadde ng'azannya ali bulungi naye bw'olaba ng'akendeera ate ng'alya n'anywa bakubiriza ogenda ku muddwaliro basooke bakebere abaana balabe ki ekibaluma so si kweyiyiza boka okweddoozingira nga bbo ate n'ekirala ng'omuzadde nga atuusemu eno embeera nga ffe gye twalimu tulekerawo okuwuliriza nnyo abantu bye batugamba kubanga omuntu asobola okukuwabya ate n'akusuula mu nsobi kubanga kati omuzadde n'akugamba omwana dogo omwana bamuloga oli n'atuuka okuleetera omusawo n'aleeta n'enkoko biki ate ng'omwana ng'ali mu mbeera mbi ng'alinga skeleton bagamba omusitule wano mu mikono nga tosobola ng'olowooza obukono bujja buvaako naye mukama yannyamba nampa omutima omugumu ne sitawuliriza bya neighbour wange byeyanga.
Once again, you are welcome this morning. It's a Monday. My name is Viola Sasia, and we are happy to have you here. Today we are talking about leukemia, especially in children, even though it can also happen in adults. And that what you just watched there is a story from Bridget Namatovu. Then we have Arieli Ariganyira. Those are parents to Deus who survived leukemia, thank God. And so we are going to be talking about this today in detail. And in studio, we already have Dr. Mwebe Victoria Katasi. She is a pediatric hematologist oncologist with Mulago National Hospital. Thank you so much for joining us this morning.
Thank you so much for having me, Viola.
So Victoria, we are going to start off with a simple explanation of what leukemia is.
Leukemia really is a cancer of the blood. Now, it's good for people to understand that in the blood we have three specifically different types of cells. We have the white blood cells, red blood cells, and what we call the platelets. So when we talk about leukemia, we are considering especially the white blood cells, the cells that help to fight infection. So it's a cancer of the white blood cells. Okay. Yes.
So how does this leukemia, get to be seen on the surface once it's happening inside? And at the time, what is exactly happening to the blood cells, the white blood cells?
So maybe I'll begin with what is happening to the blood cells. It will help us better understand what you see on the exterior.
Yes.
So blood cells are made within something called a bone marrow. So I want you to imagine like a pipe.
Yes.
So the bone has a hollow inside, or a pipe inside, a space. And in that space there's a soft spongy material called the bone marrow.
Yeah.
So in that soft spongy material is where the blood cells are made. So the white blood cells, red blood cells, platelets are all produced within there. And then from there they are actually churned out and they go into the rest of the body. So at that level of the blood cells in the bone marrow, there's a big cell called a stem cell. Now this is the one, it's like a mother cell, let's call it a mother. And this mother cell is what divides to give you the smaller cells that then go out into the body to do the different types of functions that they do. So you will get a genetic change. So this occurs at the level of the gene, that something happens or changes in the DNA of this mother cell. And so it will produce white cells that are different from what the normal white blood cells should be. Now the problem with these white blood cells that it's producing is that they have an ability to grow excessively. So they multiply so fast, and then also they are able to evade the mechanisms by which the body normally kills those cells. Okay, so they will multiply a lot and they can't be destroyed easily as the body would. And so because of that, you fill up the whole bone marrow with these cells that are abnormal, and then they move and spill into the rest of the body. It's also good to note that they are defective, so they are not able to perform the normal function that the white blood cells should perform, that of fighting infection. So now what you see on the exterior comes about because of, one, these defective cells are filling up the bone marrow. So the bone marrow is not able to produce the other cells like the red blood cells which make up blood. It's not able to produce the platelets which help you to stop clotting. So these children usually come in with anemia. So you'll hear people saying, you know, my child is pale, or they are white, the palms look white, the eyes look white, they have no blood. Yeah. Some children come in when they are bleeding, so they are bleeding from the nose, from the mouth, from the skin, because your bone marrow is no longer able to produce these other cells that are responsible for these functions in the body. But also because the white blood cells you're now producing are cancer. They are not doing the normal function of fighting infections. These children usually get a lot of infections. So they will come in with very high grade fevers, okay? Maybe someone gets a flu and they are really down and they are so sick as compared to what a normal person would have, you know, experienced a flu-like. Then also because of those cancer cells growing in the bones, they will come in with a lot of bone pains. Really, they don't want to touch. There's usually a lot of pain. So there are infections, they are sick, there's a fever, you know, they have pain, they are bleeding. Yeah, those are some of the things that you will see.
In Delsey's case, the mother says that he lost so much weight all of a sudden and became, I think, darker in skin tone and all that. What is that about?
So the weight loss can be at two different stages, and this is where I want to explain it like this. It could be at the point before we start treatment, but it could also be somewhere further down treatment. So before we start treatment, normally all cancers have a characteristic that because they are growing so fast, they are aggressive. Your body uses up a lot more energy to support the growth of the cancer. And so because of that, these patients usually present as really small and wasted, which we call cachexia in medicine, because you're extremely, extremely small, because your body is using up a lot of your resources. And also because it comes with decreased appetite, as any illness does. So they're really eating less, but also burning up the little resources that they have of energy.
So for any parent out there that is watching, could you say one child could be more at risk than another child, or are all the children exposed?
So there are certain factors that actually increase the risk of a child getting leukemia, and so the risk is not the same throughout all children. So maybe also to note before we talk about that is that for most of the children who get cancer, and now specifically we are talking about leukemia, we do not know the cause or what has actually predisposed them. But to the small percentage, there are those that have risk factors. One, there are those who have a family history of cancer. And some cancers predispose you or increase your risk or chance of getting leukemias in the children that you will have, or even those that will be had by your sister or brother. So there are cancers that move in that it's a family of cancers. Like if you have some types of brain tumors, bone tumors, breast cancers, there are some leukemias that move along the same line. So your auntie could have had a breast cancer, and your niece, her niece, okay, will have a higher chance of getting leukemia. Okay, then also there are some other factors. If a child has some syndromes. I'd like to, in lay terms, maybe I would say it's some children are born when they look different from what a normal child looks like. And the most common that we see is what we call Down syndrome. I think that one, a lot of people are conversant with it, that even when you look at the face of the child, what they look like is different from what a normal child should look like. Sometimes their ears are in the, they're a bit lower, the eyes look different, the mouth may be different, even when you look in there. So these children usually have certain other conditions that move with a syndrome. So children with syndromes like Down syndrome have an increased risk of getting cancers, especially leukemias, of getting leukemias. Not all of them will get it, but the chance that they will get it is higher than for a child who does not have it. Now,
why is that?
Well, so it's just because of the genetic changes that occur within, because actually the Down syndrome comes from an addition of one of the chromosomes at chromosome 21. So remember we said also leukemia streams from changes in the genes or at the level of the molecular level. So those things are what make it easier for somebody to actually get the cancer. Then if you've been exposed to certain chemicals, now there's what we call radiation. The biggest source of radiation that we have is if you've gone to do like a CT scan or an X-ray. Now, not everybody who has done a CT scan or an X-ray, is going to get cancer. But the more you do them, so continued exposure. And also because we have variations in our genes. Some people's bodies react better, some react differently. So what we are saying is it carries a risk. And then also in treatment of cancer, there is something we use called radiotherapy. So if you've ever had radiotherapy before, it also increases your chance of getting leukemia, even if your original cancer was not a leukemia. Yes.
All right. Yeah, I see there is just so much there. What are some of the? How can we separate leukemia symptoms from other illnesses that might present the same way?
So, especially in the early stages, it may not be very easy, especially for somebody who is not trained to be able to tell the difference, because truth be told, they present like any other child or who has a malaria. They'll come in with a fever, mommy, I have pain here. And even sometimes children with malaria also come in with low blood, so they are also pale. Because it also can affect you, it causes hemolysis of the red blood cells. So it may not be easy for somebody who is not a doctor to tell the difference. So the best way is to see a health worker whenever your child is not well, because there are some other additional tests that we do, and these additional tests, even in the early stages, can help us tease out the leukemia. Yes. At
what stage would you advise a parent to bring their child for specifically a leukemia test? In order to sort of maybe reverse it, if there is a possibility?
So maybe also it's good to know that it's not preventable. And that's the thing about most childhood cancers, is that one, we may not be able to prevent them. Unless you avoid some of the things I've talked about, like radiation. But if it's treatment and you need it, you need it. So, there's nothing you can do. And also, we do not screen for it. Meaning that, you cannot come before the cancer has come, and then we check and say you're going to get it. No, not like adult cancers. So I think that it's just for any parent to be vigilant. If you notice anything in your child that is abnormal, visit at least a child specialist, a pediatrician, and that would be the starting point, because most pediatricians have been trained to be able to at least suspect that this looks like a leukemia, and not just any ordinary malaria. And if they suspect, then they can send you to us, who are now the specialists trained to treat the cancers, and we can further investigate and make the diagnosis.
Okay, so what are some of the treatments that are available for leukemia, and at what stage can it be healed? I understand Delcy's got healed.
Yeah, so, and just I'd like to say this at this point, that cancer can be cured, and not just leukemia, but cancer can be cured. Also, what we didn't say is that leukemia is the most common cancer in children worldwide. Even here in Uganda, in our statistics, we actually have seen that it's the most common. So about 50% of the children that you will meet on a cancer ward or in a cancer program or unit are going to have leukemia. So it's very common. But also, it really has very good outcomes. Now, it has two broad it has two broad groups, let me say, what we call the acute lymphoblastic and acute myeloid. I don't want to go too much into the medical, but the reason I want to bring this up is because the commonest of those two, the acute lymphoblastic, which people call ALL, is also the one that has very high survival rates. For us, when we talk about cure in Uganda, we talk in cancer, we talk about survival rates. That from the point that you get your cancer, what is the chance, or what is the percentage of all those who have gotten that cancer that in the next number of years, and maybe if you say 5-year survival, that they will be alive? Okay, so when you look at acute leukemias, the survival rate, especially for that ALL, which is the commonest, are about 85 to 90. Worldwide, actually some countries have moved on to about 95%, okay, cure rates or survival rates within the next 5 years after a child has been diagnosed. That shows that the cure rate is extremely, extremely high, and the survival is actually good in these children. So if somebody comes early, you make the right diagnosis, start treatment, these children can actually do very well.
Yeah, I understand. Yeah, you mentioned you don't want to go into the medical that much, but could you please just give us options of treatment, especially here in Uganda? I'm interested, and I'm sure viewers are interested, because you want to understand, can I afford that? Should I just let the child be? That kind of thing. Okay,
so and like we've started off by saying, it's curable. It's also good for people to know that treatment for cancer in Uganda is free, depending on where you go, of course. But I know that the two biggest areas, sites in Uganda, especially in Kampala, that treat are free. Okay. So I currently work in the Mulago National Referral Hospital, and there we have a pediatric hematology oncology department. And so that is specifically a department that treats children with cancer and blood disorders. Okay. And treatment in there is actually free. All you have to do is bring your child if you've been referred because somebody suspected, or you showed up at ADO because you thought it could be, and we've investigated and the child has cancer and it's a leukemia, we start treatment. So of course, maybe what patients or parents will need to know is the patience that they need to have, because this journey is not a short journey, and it is not an easy one as well, both on the child and the family as well. If you have a boy, the treatment for leukemia is 3 years. If you have a girl, the treatment is 2 years in total. So it's the patience that we need for you to know that I am going to walk this journey for 2 years or 3 years with my child. And it's not a smooth one. Why? Because when you start drugs, the drugs that we use, you're asking about treatments. So the drugs that we use to treat cancer, ideally are called chemotherapy, anti-cancer drugs. So chemotherapy has a lot of its own side effects. It's a lot stronger than what you would use for normal drugs, like for normal diseases like malaria, anti-malarials, okay? So here children get a lot of things like a lot of oral sores up to their throat. So they, at certain points they can't eat. So you'll have to put like a tube to help them eat. You know, a child can come in and the chemo can also make you bleed, because it's supposed to wipe out the cancer cells, but it can't tell the difference between normal cells and cancer cells. So it wipes out every cell in your body. So at the point of when you came in and you can't fight infection, we actually put you in a worse place where you can't actually fight your infection. Okay, so for some time we practically put you at a point where you are defenseless. And so here we are keeping you on the ward, and we are supporting you with different drugs that we use, you know, to make sure that you don't get infections. If you get them, we are treating them and things like that. But the side effects are still there. So sometimes they come in very high-grade fevers because we've really, you know, suppressed the ability to fight infections. You know, the bleeding may come in once in a while. They'll require blood, they'll require platelets, but all that we support you through, okay? And it's for you to understand that we walk this journey with you. This will come, but it's for a time. They also talked about discoloration of the skin. They said the child turned black, okay? That mentioned something like that.
Gained weight, lost weight, you know, changing on them.
So that also comes in because of the treatment, especially because when you treat leukemias, especially the ALL that I talked about, that is the most common on the two leukemias, the acute. One of the major drugs we use are steroids. Steroids are these drugs like prednisolone, hydrocortisone. You hear a lot of people use, you know, when my child has a flu, they go and buy dexamethasone, or they buy a prednisolone. People in the Ugandan market actually use steroids a lot. So steroids is part of the fundamental chemotherapy that we use for leukemias. Now, part of the side effects of steroids is that it makes you put on weight or accumulate fat in certain areas of the body, the cheeks. And so when you walk on the road, you'll see these kids with really puffy cheeks, and then abdominal fat and fat around the upper part of the back, okay? And that comes in because of the distribution of the fat, because of the steroids. Now, they'll do this for about a month. Then we will wean them off the steroids. So then this goes away after you stop giving the high dose steroids. So Mom also talked about an increase in appetite. It's also a side effect of the steroids. They actually cause a high appetite. And so you'll notice that most of these kids in the first phase of treatment who are on the steroids wake up even in the middle of the night and they are demanding. I think it's beyond asking. They are demanding, like they just want to eat all the time. And that also fuels the weight gain that you see in them. But it still passes after that phase is done and the steroids are actually taken off. Then the color changes, the skin changes. You see the nails really change color, they become black. The hands, the feet, the hair falls off. All this is because of the treatment. And like we tell the patients, when you finish the treatment, all these things slowly start coming back to normal. So it's really temporary.
Thank you so much for that in-depth explanation. I hope that our viewers are understanding what you have to sacrifice in order to get cured, actually, or get your child cured. We shall be talking about whether there are alternatives to chemotherapy when we return, Doctor. But for now, we have a commercial break that we are going to take. Do stay with us. NTV Medical Matters returns shortly. Welcome back from that break, and thank you so much for staying with us on NTV Medical Matters. We are supported by Bill and Melinda Gates Foundation. I am Viola Sasya, and today we are talking about leukemia in children. That is childhood blood cancer. We have in studio with us Dr. Mwebe Victoria Katasi. She's a pediatric hematologist oncologist at Mulago National Referral Hospital, and we are so happy once again, Doctor, to have you here. I just want to remind our viewers that the phone lines will be open later on. If you need to call and ask questions, do so, because the doctor will be here with us for the next 30 minutes. So continuing, we had spoken about chemotherapy. So I just wanted to understand whether there are alternatives to chemotherapy, because it comes off really intense and very hard on the child.
So indeed it's true that chemotherapy is very intense. And the reason that the treatment used to treat cancers should be intense is because cancers are also generally very aggressive. So worldwide, in the treatment of cancer, your first line for treatment, especially we are talking about leukemias, your first line for treatment is chemotherapy. So whether you're in the US or in the Americas, Europe or Africa, really you can't run away from chemotherapy. That is your first line of treatment. And you will also find out that probably also in other countries like the US and Europe, they are even using more intense chemotherapy than we are using. Because how intense the treatment used depends on how much you can support the child. You see the things we've talked about, that when we give it to you, get side effects, the complications, you know, that your counts are going down, so you can fight infections, you're bleeding. So if you're able to support a child much more through that, you can even afford to give them more intense and drive them to a really lower point than we do it here. So which means that we give them the best that we can, which is actually part of the protocols that we have adapted from there, but there are things we can't do, like stem cell transplant here. So we may not give the extent of intensity that they do out there. But part of the other treatments that you can use in treatment of cancer can come at a later stage, like bone marrow transplant. This will happen usually if your patient has failed to respond to the chemotherapy. So when we give you chemotherapy, what we are looking for is for the cancer cells to totally be cleared out of your body and your system and the bone marrow. We call that going into remission. And for us to extend your treatment up to 2 years is to make sure that whatever else may be hidden that we can't see is totally wiped out, and we are also increasing your chances of the cancer not coming back, because when you treat cancer, it may come back. Relapses can occur. So there are cases where you will treat a child and the cancer cells persist. You've given them as intense of the chemotherapy as you can, but still every time you go back and check, they are still there, and to quite a large extent. So those are the children where you want to push them to a point. If you're able to clear, then go and do a bone marrow, bone marrow transplant, what we call a bone marrow transplant, and be able to wipe out their bone marrow completely and infuse them with the cells of a bone marrow that has been gotten from someone else, a donor that is compatible, and then support them through that. And then the other treatments that they use out there, there's what we call targeted therapy, but this would also be used in conjunction with the chemotherapy, not outside the chemotherapy. So when you look at the leukemias themselves, you can put them into subtypes, And so because of those subtypes, there are certain treatments that have been developed that can target particular subtypes. So these targeted therapies can be used for that particular leukemia in addition to the chemotherapy that you're using to improve the outcome and the chances of cure.
Just a quick question. Why is it that the girls take 3 years and the boys 2 years?
No, the boys take 3 and the girls take 2.
Interested. Okay, so why is that?
Okay, that's because the boys have an extra site, and that is the testicles that we call a satellite site, where the leukemia cells can hide. And so you're making sure that you're wiping that out also as well, whatever may be hidden within that.
Okay.
Yes.
Thank you. So what guarantees that a given child is going to recover either faster or later than the other child, regardless of the intensity of the leukemia? Perhaps maybe their lifestyle or their bodily, functions or something.
Okay, and I guess the question that you're asking, if I rephrase it, would be what determines your response to treatment, right?
Yeah.
Because you will treat and somebody, after the first 28 days, they have responded and you check and the cancer cells are gone. And yet for somebody else, you'll check and they're still there. Because ideally they should be gone after the first 28 days, the first 1 month.
Okay.
And then we just continue with treatment. So this also will depend on sometimes the subtype of the leukemia that you have. Remember we said there are subtypes. So there are different changes that may occur at the gene level. And so depending on some of the changes that have occurred, some of those leukemias, the subtypes are more aggressive and have like a, are more difficult to treat, let me say. There's something we call infant leukemias. Infants really are any child who is within the first 1 year of life. But even those who are older than 1 year may get that leukemia. We still call it infant leukemia because of the changes that have occurred at the gene level. Okay. This leukemia does not usually have very good outcomes. And so these ones may be one of those who you will treat and still the cells may persist. So it's the subtype of leukemia that you have. And then also for some it is at what point you presented. So there are children who will come in and their leukemia has progressed, and you will see that when you just do a simple blood check. Like if your child is sick and they have a fever, you walk to the doctor. There's a blood check that we do called a complete blood count. So on there you can see what do the white blood cells look like, the red blood cells, the platelets. So now in some of these children, they will come in and they have white blood cells that are 100 and plus, okay? As long as your white blood cells for the acute leukemia are more than 50, times 10 to the power 4, okay? That means you get into what we call a high risk. And so for people who have a high risk leukemia, their chances of response would be a bit lower than the people who have a low risk leukemia, because they came in with, their disease is less aggressive. They came in with lower blood counts, like maybe someone had 10 and you have like 100. You realize that your disease is more aggressive than the other person who came with just 10. And so you're more at risk of not responding as well as the other person. Yes.
Okay. So what would you say are some of the biggest challenges that the parents or families of these children that you have attended to especially, what are some of the biggest problems that may cause, some of the parents not to bring the children, or to bring them and then not continue treatment or something like that? Deuce's father wanted to stop the treatment. He really admitted, it's like, I just got tired. So what are some of the things you've seen?
So first of all, to understand that the journey is not a smooth journey. If any of you has had a sick child, you can imagine what it is if your child just comes up with a severe malaria and you're in hospital, they are hooked up on a drip for these 4 or 5 days, they are burning up with a fever, and the fever is not coming down. The amount of anxiety you have. Now, I want you to imagine your child in a much sicker state, okay? They are lying on bed, they are bleeding from the nose, the mouth, the urine, the skin, okay? They are not able to eat because they just lack appetite, they are burning up, they are wasted, and then we are hooking them up on all these lines, putting up their blood, giving them this intense treatment. They have this pain, though we still give them painkillers, but imagine your child in that state, and this is a child, not even an adult, So sometimes I find that it's difficult for parents to actually deal with the amount of pain and suffering that their children are actually enduring, because leukemia can get you as early as in utero. Like you can give birth to a child and already had a congenital leukemia. So sometimes we have kids who are as young as 2 months, 3 months, and they're on treatment. You're hooking them up on all these things. You have older ones, okay, who can talk and say, "Mommy, I'm in pain. Mommy, here is bleeding, hurting," and things like that, So I find that the ability to actually adjust and deal with the sickness of the child is difficult for some people, and we have to do a lot of counseling for them to help them adjust. But also for people, the journey is long. Like I said, 2 years for girls, 3 years for boys. So along the way, people get tired, because this journey includes frequent hospital visits. Depending on the phase of treatment that we are at, sometimes you have to come on a daily basis for your child to get treatment, because some treatments are IVs. And then we have to keep doing blood counts in between. Then sometimes you come like once a week or once every 2 weeks, but you're not doing that for 3 years. Is long. You have to be very committed to this, okay? And for some people, it's also the balance of, okay, I am working and maybe I have a family that has other children, I have other dependents, and maybe I am, you know, the main provider of the family, or even we are both working, me and my husband, and we are both providing, but we need both incomes to sustain the family and other things. So that failure to keep up the finances of the other burdens that they have, take the other children to school and things like that, sometimes makes people feel like the journey has become too heavy for them to keep on, because you need to give attention to this child who is also very sick and you're spending a lot of time in hospital. In fact, I've seen a lot of people take leave from work if their work is understanding their workplace, for them to actually dedicate that time and be able to be there for their child and be able to do all the visits and things like that. And those who fail to come back sometimes, those are the reasons. Look, I was losing my job and I have other children to sustain and things like that. Yeah.
So for parents who might be thinking, oh, that's too much for me, I can't risk going, I can't, you mentioned that it was free, there was availability of free treatment. Could you please shed more light on that, the treatment availability, the centers, as well as you know, any other information we need to know this moment? Okay.
So also depending on which part of the country that you're at. Now in Kampala, we have our program here in Mulago, under the Mulago National Referral Hospital where I work, but there's also a children's cancer ward in the Cancer Institute. We are both on the same hill, really. So both centers treat children with cancer. If you're in the West, Mbara Regional Referral Hospital is also one of our sister hospitals that we work with, and they also have a program for cancer in children. And then Gulu, I think, also has started, Gulu Hospital, so they also treat a few of the children. I'm not sure exactly at what capacity, but I know that they do some. And also Lacho, over time, has been doing some treatment for the children. So depending on where you are, you can access any of those sites. Treatment is free. Indeed, treatment is free. And the center that I work at, our program is both donor funded in addition to government funded. So our anti-cancer drugs are really accessed through a program called the Global Hope Program. Hope is Hematology and Oncology Pediatric Centers of Excellence. And this is under the Texas Children's Hospital and Baylor College of Medicine in the US. So under this program, they have set up a number of satellite hematology and oncology centers all over Africa. There's one in Botswana, there's one in Malawi, there's one in Kigali, there's one in, they also work with people in Tanzania, in Kenya, and here in Uganda, really to promote survival of children, diagnosis and survival of children with cancers in low resource settings, and we are here in Africa, But at the Cancer Institute, we also work with the government as well for some of our supportive drugs, antibiotics, and so on and so forth. And the Cancer Institute, I think, would be purely government funded because it's a national cancer institute. But for either programs, the patient does not incur a cost. Because you come in and get everything done for you for free, whether it's the investigations you need, whether it's the treatment that your child needs, all that is given to you for free. And through some Good Samaritans, now we have some hostels that have been built around, so that if you're the kind of person who comes from far, you know, some patients who come from Gulu, from Bale, and if you remember we said that treatment is a bit intense, we need to come a bit more often, like daily for some visits. So they put you up in the hostels, an attendant and a child, they provide food for you, a place to sleep, and they have a car that brings you daily to the unit to get your treatment and then takes you back.
That's such a relief. I enjoyed listening to that. That's the best part of the interview, I believe. Knowing these things are available and they are free. So I really hope that, dear viewers, you're taking notes just in case you have a sick child out there. Do not put them away. I don't think it's witchcraft. Just do not hide them away. Just go seek treatment. And you mentioned something very important, Doctor. You mentioned that a child could actually be born sick. So is there a way that that can be determined before they're born? Does the mother's lifestyle affect the child maybe, and could be the cause? Please talk to us more about that.
Okay, so I had previously talked about congenital leukemia. Really, congenital means that you have been born with it. So some children actually will develop the leukemia in utero when you're still a fetus. So is it the mother's lifestyle? So would say a few of the children, and those are where you have those genetics within the family, that maybe we have a hereditary predisposition, that in my family we have those cancers, may be the cause, but not for all of them. For some of them, it's still just a sporadic cause. It has happened on its own, and a change has happened at the genetic level. Because you remember, in utero, the baby is being formed. So during the process of forming the baby, some things can go wrong at that level of the gene, and so a child can be predisposed to actually being born with a leukemia. Now, can a mother tell? Normally, if your child is not growing well, the baby inside the fetus is not growing well, there are certain things that we may see or may not see. So sometimes women come in and they have extremely large amounts of liquor, that fluid that surrounds the baby. It's more than it should be, polyhydramnios. Sometimes it's less than it should be, oligohydramnios. Those are some of the things that we may see and start suspecting that maybe there's something that is not right with this baby. And if it's a baby that has a syndrome, because we said also some syndromes may predispose you to, when you do a scan, sometimes you're actually able to see that there are some abnormalities in the baby, and this they can tell you during utero that your baby looks like they have a bit of a syndrome, something is not okay. Yeah, and at birth when when you have them and then you're showing signs of things like anemia and so on and so forth, the two can tie together. Yeah.
Okay. Well, you had already crushed my hope that it's not preventable, but I still want to press harder. Are there lifestyle changes for a child that can make this journey a bit better? Say, for example, foods, the food choices, and after recovery. After recovery, what are some of the things the child or the caretaker has to look out for this child?
So the lifestyle changes we're talking about are in the children who have actually had the leukemia or those who have never had it before?
Both.
Both. Okay, so maybe let's start with the ones who have never had it. Okay. So really, apart from growing up as a normal child, making sure that your child is fully immunized like they should be, because some of the things that also increase the risk of getting a leukemia are certain viral infections. So of course, immunizing what we can immunize, okay, to reduce the risk for some of those. And then remember we said some things like radiation. I mean, if your child got sick and they really need to go to do a chest CT scan, they need it. So we are not going to say don't do it. But of course, if it's not necessary, and this will be at the discretion of your medical personnel, they think through it and say, does the child really need it, And maybe if they can do something else that is not it, then we can do something else. Because there's other imaging modalities that don't use radiation, like the MRI, magnetic resonance imaging, but it's more expensive. And so a lot of the people here in Uganda cannot or do not seem to be able to afford it as compared to a CT scan and an X-ray. Okay, but if your family can afford it, then you can ask for something that is more expensive, depending on how old your child is. But otherwise, really normal, eat a normal diet, live a normal life. And then the ones who have, like, if your child was born with a syndrome, like the ones we've said may predispose you to, what we are talking about mostly is Downs, because a lot of people know what Down syndrome is. These ones, you just have to be a bit more observant and keen, and make sure that you maybe do frequent hospital visits, okay? So maybe checkups, like everybody needs to have a checkup. You will have to be strict on making sure my child gets their annual checkup, because, they can catch some of these things early when they come in. For a child who has had leukemia before, so maybe during the process when you're actually on treatment and after treatment, what we really advocate for is to eat a balanced diet like every other child. When you read a lot of things on social media, people will talk about things like don't take sugar, I don't know, special diets that people should have, either become a vegetarian or things like that. But a lot of these things have not been supported by solid research findings. And so they are not things that we are advocating for in our patients, and especially for children. Children are like adults. We do not deny children food, okay? So if once in a while she says, I want to eat chips, for heaven's sake, she's so sick, she's basically not been able to eat for like the past 3 weeks. She wants to eat chips this once. Give her chips. You understand? This is a child, But of course, we advocate that have a balanced diet, okay? Yeah, so eat whatever you need to eat during treatment and after treatment. Maybe one of the things that we discourage is, especially when they're on treatment, eating a lot of salads and raw foods, especially at the point when their cell counts are very low. Because at that point, remember, I said your body is defenseless, you can't fight infections. Now, these greens that are uncooked may carry some germs, organisms on them. And so if you're not really properly cleaned them, you don't know how properly clean you've done it when you just wash under your sink, you actually predispose the child to a risk of getting infections because of eating these kinds of things. So in that process, we tell them, cook everything you eat, cook. And if you're giving me a fruit like an apple, peel it, okay, to reduce the risk of things like that. Yes.
You said it could actually return after someone gets healed.
Yes, it can.
So what could cause a resurgence of leukemia in a healed child?
Okay, so every time we treat a cancer, there's always a risk that it will come back, so that you'll have a recurrence, what we call a relapse. And literature has actually shown, or there are published statistics of, depending on which cancer it is, what is the risk that you carry that your cancer will come back, okay? And those are part of the things that we talk about with patients even when we are starting treatment. Okay. That even at the end of the treatment, we do not say you're cured, even if we can't see any more cancer cells. No, we don't say cure. Even when we can't see any more leukemia cells, what we say is you're in remission. That we've been able to control the cancer. Okay. We can't see the cancer cells, but we are not declaring you as cured at that point, because we know that at any point it can come back. So usually even when we treat, we keep the kids in the clinic for about 5 years, and in those 5 years it's just a follow-up. You come in and video counts at different intervals, check on you and see if when we catch it, when it comes back, we start treatment. Or if it comes back when you're home and you notice, you know, we start treatment. So what may predispose the cancer coming back? Previously we had talked about subtypes of cancer. So there are some of those subtypes that are more difficult to treat. They may carry a higher risk of, even when you have treated, they are refractory to treatment. And so these ones may have a higher risk of coming back. But also these cases where the children are not coming for treatment as regularly as they should because of the different problems that occur in the families. You know, today mommy got sick. There are cases where we've had patients and the parent will say, I've been admitted in hospital for 2 months. There was absolutely no one who could bring my child. So the child needs treatment for all the time, you see. We have parents who are single parents and the mom is like, I had all these other children to take care of. I couldn't come because I couldn't get leave from school. So, you know, that's what I'm doing. I'm working as a teacher. So my child could not come, and they come in when the cancer has come back. Sometimes they are, you know, disagreements between the parents that we have seen, and because the parents then separate either at the point of when the diagnosis is made or before, one parent will then take the child away for like quite some time, and then when they bring them back, maybe they went to seek care elsewhere, and elsewhere is like, you know, traditional things. They're like biachika, you know, so we go to sort out the biachika things. By the time they come back, the cancer has really relapsed. So yeah, it's an interplay of factors.
I would actually request you to speak directly to the parents who are watching and who believe in these things. You know, like the father of Dale said that at first his neighbors forced him to bring a white hen and all this stuff is witchcraft. So could you please communicate to them a bit?
So cancer and leukemia that we are looking at, which is really a blood cancer, is an illness like any other illness that you see. Malaria, okay, or your child has come in with a diarrhea or a cough and a flu. It's just that the cause of this illness is different, okay? In malaria, it's I've gotten a mosquito and then I've come infected with Plasmodium, you know, malaria. This is because there's a change in the genes within the bone marrow of my child. And so my child is producing cells that are not normal. And this is what is causing all the things that you see, the symptoms. And so it has nothing to do with traditional or with being demon attacked, because we also have parents who take children away and take them to church. And then the child has been at a church for about a month. By the time they come back in, they're really a lot worse than they left. What we advise, that depending on whatever your spiritual denomination is, we do not stop you from practicing your faith, because also as you realize that in treating illnesses, and especially treating cancer, part of the healing has to also include part of your beliefs, whatever your spiritual belief is. We don't stop you from praying, but we want you to do things alongside us. However, there are things we refuse you to do, like giving children certain things, of certain herbal concoctions that we do not understand, because these, one, like I said, may predispose your child to more infections because we don't know what's there, but also they may interfere with the treatment that we are using. But if it's just spiritual, like they are praying for your child and things like that, please go ahead, but do not interfere with the treatment. This you can do alongside the treatment. Take the child to see a pastor. From a time when we've discharged you and said, okay, you can be home for 2 weeks, come back, you can go and see your pastor. The pastor can come and see in hospital. It's actually also allowed in hospital. You can seek permission, come and pray for the child, but not interrupt treatment because of this.
Okay.
Yes.
That's very clear. So as we wind up, could you please talk to us about how this childhood cancer or leukemia is related to the leukemia in adults?
Okay, so we had previously said that there are two particular subtypes. We're looking at acute leukemias, the acute lymphoblastic ALL and the acute myeloid AML. However, there's also what we call chronic leukemias, and these occur both in adults and in children. You have the acute leukemias and you have the chronic leukemias. Now the difference is that in children, of the two subtypes I talked about in the acute leukemias, the acute lymphoblastic leukemia is more common in children, and it's also more curable vis-a-vis in adults where the acute myeloid leukemia is more common, okay? And it is less curable, both in children and in adults. The outcomes are not very good. And also you realize that for us in children, like some of our risk factors include things like syndromes. So maybe a child had a Down syndrome, some other syndromes like Leukemia or Noonan's, which you won't find in adults because you're not going to just develop a syndrome when you're an adult. So basically that is limited to us in children. The survival is really much better in children as compared to adults. And so when you look at the statistics, if you walk into a cancer ward of people who have leukemia in children versus in adults, you'll find that the outcome is much better in children as compared to adults. Yes.
So I think, Doctor, we shall have another time to be able to talk about leukemia in adults separately as itself, but for now we are going to be leaving. So any last words to our beautiful audience? Okay.
Thank you very much for tuning in and listening to us. I would like to leave you with a message that cancer is curable. Leukemia is very curable, like we have said. It's the most common cancer in children, but also it has very high cure rates and survival rates. As long as you bring the child on time and you keep getting your appointments regularly and the child keeps on the treatment, it's very curable. And the beauty is that you do not walk this journey alone. We have a team of trained specialists. Currently in Mulago, we actually have about, we are 9 specialists, and then we also train other people like us. So we have currently 3 fellows, and there are 6 that are joining today. So our team is big. And then we have a number of nurses who have actually been also trained, especially in hematology and oncology. Our pharmacists are trained in that same field. So really very specialized people who walk this journey with you. We also have a psychologist on board because we know that there's a lot of psychological issues that occur in the child and the parent. So we do a lot of counseling also to support you along the way. And whatever the issues are, we work together with you to help support, sometimes even financial. We support our patients in things like this, even that have nothing to do with a child. Like my business, failed and I have to start to get a business. So we kind of help with things like this because we want to make sure that the child is able to continue getting their treatment, and also past the treatment when they are surviving, that the family can also actually be able to thrive and take better care of them. So please come and seek care. Leukemia is very treatable, and there's a team of people that can work with you. And if you hear the message, please spread it to those around you. So if you suspect, please visit any nearby children's specialist, or you can come straight to us to Mulago, and we can be able to help you. Thank you very much.
Dr. Victoria Mwebe Katasi, a pediatric hematologist, oncologist at Mulago National Referral Hospital. Thank you so much for your time. We appreciate that hopeful message. And to you, dear viewer, we've come to the end of today's episode of NTV Medical Matters. We are supported by Bill and Melinda Gates Foundation. I am Viola Kusasira. It's really been a pleasure. And until the next episode, have a lovely week.